Good afternoon. My name is Michael Erickson. I'm Dean of the School of Public Health, and on behalf of the Georgia State School of Public Health and on behalf of the university, welcome to the second annual Kreuter Katz Lecture on Health Equity. I'm delighted you're able to join us today as we honor our dear friends Marshall Kreuter and Martha Katz and their contribution to public health and their dedication to health equity in this special issue. Today, we're honored to have Jim Marks here today, who will be our keynote lecturer on health equity. But before we go into hear from Dr. Marks, we have a video to provide some background on why we're holding this lecture series and for you to learn a little bit more about Marshall and Martha. After the video, we'll introduce Dr. Marks and proceed with the presentation. Our public health program at Georgia State is really focused on applied public health and urban health. So urban areas often have the greatest disparities, and we try to do real work in the communities to understand better and address these health disparities. Marshall has been a real leader in this regard. He has opened the door to our students and our faculty about community-based research and listening and learning and respecting communities in order to understand how best to address these health disparities and achieve greater health equity.
Martha and Marshall are special people. They are committed to social equity, committed to public health, bring a mixture of skills between them to it. In fact, you could have a School of Public Health that was largely based on the faculty of Martha Katz and Marshall Kreuter and would cover most important subjects in it, and the students would enjoy it tremendously.
I began my career as a school teacher almost 50 years ago, 45 years ago, and I have always been committed to trying to create experiences that will help students learn and see the value of the content that they're dealing with. When I went to Georgia State to join what was then the Institute of Public Health, which is now the School of Public Health, I began doing that, and my bias for experiences probably led me into my own interest, which is community-based participatory research. I'm very grateful to Michael Erickson and his colleagues for providing support for a project that we did at Georgia State called Accountable Communities Healthy Together. It was a research project funded by the National Association of Minority Health. And we went into urban Atlanta and used the same principles we've been talking about, community engagement, listening to them to try to address the health problems that they had. And it's a really good example of understanding the importance of listening to people.
I think the process was great. Whenever you have an opportunity to engage community into defining what the issues are that confront the community, I think one of the things that we as practitioners got to learn how to do is to listen to community, though. A lot of times we come in and we understand the process and we're so pointed on the process that we don't really hear what community is saying to us. And one of the powerful things that I've learned in my organizing is that the most powerful thing that we can do is listen.
Some 30 years ago, I had the opportunity to meet Marsh, who was a professor in health education at the University of Utah. And what I recall about his experience there and my experience with him was the training and education opportunities that he afforded students. One of those, a very unique experience, which I would call immersion learning, where he would put students in real-world situations so that they would understand and appreciate the circumstances of the underserved, the institutionalized, the marginalized. And so from the very beginning, one could see the DNA in Marsh that spoke to social justice issues. Martha as well has a distinguished career in this area, and specifically in terms of her work in health policy. We can look around the state and find a number of health policy organizations that did not exist. But when she came to the foundation, she helped the foundation incubate a number of nonprofits, health policy organizations that specifically addressed health disparities and health inequities.
You know, my 4 grandparents were all immigrants. They came to this country with very little, but somehow or other, my grandmothers and my mom every Friday managed to be able to put a little something in the charity box. So it was very clear to us when we were small children that there were haves and have-nots in this world and that we were supposed to do something about it. That, of course, spills over into what you do as a person in your career. I've had the pleasure of working with both Healthcare Georgia Foundation and GSU. I got to be an early staff member at the foundation. I got to chair the board of advisors for the then very new School of Public Health. Then it was a public health program. Now it's grown into being a school. And as a member of the Georgia Health Foundation board, I get a chance to work with both of them as a colleague from that perspective. So that gives me sort of a nice picture of both organizations. They're very different because one's a private foundation and the other one's a university, and they have different missions, but they have a lot in common because both organizations have a real commitment to health equity. They know we've not achieved our goals in public health unless they benefit everybody, and especially the most vulnerable among us.
Martha was our first chairman of the board of advisors for the School of Public Health. And even today, this award that we're highlighting the careers of Marshall and Martha is the idea of Gary Nelson and the Healthcare Georgia Foundation. And without their vision and support and commitment, we wouldn't be here today honoring these great individuals.
It makes me feel proud that the colleagues that I've worked with over the years have made an effort to help other folks, and that's why we're here, to help one another. And if this in any way benefits students, causes people to think about the importance of health equity, making health for all really something important, keeps it at the top of their mind, that makes me feel real good.
I'm sure having a named lecture series for them both delights them, and they're honored by it. And I suspect they're both a little embarrassed by it all too, because they're so humble. Well, tough luck, Martha and Marshall. You deserve this, and you ought to enjoy every second of it.
As you can see, this is a very special event for very special people. Those of you who ever have dreams of crossing the street and realize you don't have any pants on, or that you're not prepared for a test and it's all of a sudden you're sitting in the classroom, my fear is that I'd have a video or be taking a picture and wearing the same tie I did when the video was taken, and this is the first time that's happened, so I'm totally humiliated by that. But this is, despite that humiliation, this is just a very heartwarming and special day for us, for everything that you saw in the video, for Marshall and Martha's contribution to the School of Public Health at Georgia State. This year we're celebrating our 10th anniversary of having students at Georgia State, and we've had over 400 alumni. We graduated our first PhD students this past December, and we're extraordinarily proud of our graduates and the roles they're playing around the world, but particularly in Atlanta, at CDC, at ACS, at the Task Force for Global Health. All of them are playing important public health roles, and really Marshall and Martha have contributed to really developing the next generation of public health leaders, and many of them are here today and have come through our program. And many of them are contributing to our collective effort of really doing something to achieve health equity. And we couldn't have had a more appropriate speaker today on the topic of health equity than Jim Marks. Jim was my former boss. the boss of many people in the room today during his time at CDC. He was at CDC, had many positions, but he was the director of the National Center for Chronic Disease Prevention and Health Promotion. I'm one of the few people who know the right sequence of words on that center since I spent so much time there. His successor is here in the audience with us today, Ursula Bauer. And the National Center really provides the leadership for this country and around the world to deal with issues of chronic disease and health promotion. And we all know how important those issues are as we go forward. Jim currently has just been promoted to Executive Vice President of the Robert Wood Johnson Foundation, most senior position outside the CEO of the foundation. And RWJ is a very special organization. Jim will tell you about it. They're committed to health equity, and they're also committed to dealing with the types of problems that are facing this country, including, and most have to note their contribution to preventing childhood obesity, where they now have committed $1 billion for the issue of childhood obesity prevention, which is not only unprecedented, it's one of the most remarkable philanthropic commitments in the history of public health. Most recently, and Jim will tell you about, the newest initiative of the culture of health and RWJ's effort to inculcate health throughout communities throughout the country. Jim has published extensively. He's a physician by training. He's spent time in maternal and child health and reproductive health, and is one of our national leaders in prevention and public health. So please join me in welcoming Jim Marks to the podium.
Thank you. Thank you, Michael. It's a great pleasure for me to be here and speak to this distinguished audience. I want to say at the outset how honored I am to have been selected for this. It's an issue I feel strongly about, but Marshall and Martha are longtime public health colleagues and friends of mine, and I remember when both of them came to CDC. I remember playing racquetball with Marshall and golf. I was a little better at the racquetball than at golf, where I was dreadful. And it's also, I have special because it's Larry Green and Judith are here, also people who I've worked with. So this makes this a terribly special time for me. As you heard, after a long career at CDC, a little over 10 years ago, I went to the Robert Wood Johnson Foundation. Our foundation is the largest one dealing solely with health and health care in the U.S. Really for all Americans now starting to think about how we can learn more what's happening globally and bring that home. And so it's with great excitement and some trepidation that recently we've concluded we must do all we can to help our nation build a culture of health that enables all in our diverse society to lead healthy lives now and for generations to come. This means a society-wide convergence on the deeply shared value for health, and that all parts of our society, public, private, and nonprofit, work together to improve health, health defined very broadly. That we need to work towards equity and the opportunities for all to have good health. And finally, that the good quality health care that we can have in this country is affordable and accessible for all. I said with some trepidation in my remarks because it's a pretty all-encompassing vision. And given the intractability of our healthcare cost crisis and coverage challenges and our bad health outcomes when compared to other developed countries, these problems are so large they're affecting our economic competitiveness as a nation, and the divisiveness of potential solutions is eroding our sense of community as a people. These challenges are coupled with persistent large disparities in health and inequities in the social factors that enable people to have good health. All these have led us to conclude that we needed to strive for a culture of health for all. That is, the pursuit of equity and the elimination of disparity is right at the center of our new vision. Equity and disparity is such a big issue that I really found it difficult to decide what to focus this talk on. And as I thought about it, I kept coming back to some of the crucial fundamentals and themes, and I'll talk about those, but then I'll come back into what we're doing as a foundation. This map is from the classic John Snow investigation of deaths from cholera in London in the mid-1800s, the classic beginning of public health and epidemiology. He mapped the deaths and determined that people who got their water from the Broad Street pump were more likely to die. This investigation has served as a touchstone for our field ever since. Let me orient you to the map. The blue dots are water wells and pumps around London. The red dots are the deaths, and that little star is the Broad Street pump. Now, why lead with this in a disparity talk? I'm sure you can tell. Because when you look at this map, and the investigation at its core, it was about noticing a disparity, that is a difference between neighborhoods, in the clustering of deaths around the Broad Street pump. And next, being able to figure out the cause, the water source. And remember, this was a time before people knew that things like bacteria in water could cause disease. And then taking action, removing the pump handle to stop the epidemic. I want to touch a little bit on definitions, at least for the purposes of today's discussion. Disparity is a difference between groups of people. Health equity refers to the absence of disparities due to controllable or remediable aspects of health. Inequity, especially persistent or unaddressed, thus implies a kind of social injustice. It is that if a population has lower life expectancy due to lack of access to medications, to differences in exposure that lead to illness or injury, or because that group lives in a situation where they can't get maybe fresh fruits and vegetables easily, or it's unsafe for their families to be outside in their neighborhood. The difference in length and quality of life is a health inequity. And while I will today talk largely about death and life expectancy as outcomes, please be clear that I know, that we all know, we must embrace the World Health Organization definition of health, namely that health is more than the mere absence of disease or injury. It is the complete state of physical, mental, and social well-being. So let's do a quick run-through on equity, disparity, and health. I don't expect you to read this slide. I can't read it really from here. It's from an article in the New England Journal of Medicine about 10 to 15 years ago. It shows differences in years of life lost before age 75, according to education in one column and a black-white race in the other. What I want you to notice is the most obvious part of the slide. Premature deaths from so many major health conditions. Cancers, heart disease, lung disease, etc. are all heavily associated with two essentially social factors, racial heritage and education. That is, almost all major medical conditions are affected by social factors like heritage and education. So working on a single condition, like asthma or heart disease or injury, while important, is not going to be enough. It's not going to be enough to address the deeper causes in our society that affect incidence and mortality from all these conditions. I'd like to give you another one. This is higher income, longer life. I want you to look briefly at this. Most people, when they think about inequity, think essentially about the issues of the poor or black race or the less well educated and versus those that are rich or very well educated. This slide shows that length of life increases as income increases across the range of income. You can make a similar figure for education. People who earn an income that is several times the poverty level live longer than low-income earners, and that but they don't live as long as the highest income earners. Thus, inequity in health associated with income and education affects almost all of us in America directly. Again, so solutions aimed solely at only the most affected are not enough to solve the core causes of the inequities. Two main conclusions then. The social factors affect most health conditions and most people. That means we have to start to think about how we create change that at a societal level it cuts across specific health conditions and could help nearly everybody. Very fundamental changes. Bill Foege, the former director of CDC and president of the American Public Health Association, said this: "The philosophy of public health is social justice, and the primary goal of public health is to reduce or eliminate differences in mortality and morbidity between populations." In so many words, he stated that disparity reduction and striving for equity is not part of what our field is about. It is the central purpose of public health. Disparity reduction, regardless of the source, is the fundamental goal of public health. And an even more famous Atlantan, Martin Luther King Jr., said, "Injustice anywhere is a threat to justice everywhere." What does that mean for our work? It means that if injustice, think of that as inequity or disparity in health, is accepted, unchallenged anywhere, then there is a risk that the idea of unjust societal behavior or policies or structures become acceptable and can gradually corrode our shared sense of community and nationhood. And this, philosophically, is why we came to realize we have to embrace a culture of health that has equity at its core and the spread of solutions around the nation as its central strategy. And working solely within health care or working only to help the most affected individuals in our communities wouldn't be good enough. So let's move on to what we've started to do as a foundation. We've got a long way to go, and we're going to need your help, because this culture of health is not a vision we are going to succeed at. It's a vision our nation needs to succeed at, and we hope we can help. We had sponsored a lot of research and demonstrations related to disparity, and where in the past we might have spoken about individual projects or studies, we now hope to become a more prominent and influential voice on the importance of equity and reduction in disparity overall. But let's also be clear, as a foundation, we have no authority, and the amount of money we have, even for a large foundation, is minuscule relative to the size of the problems we need to address. We simply cannot fund all that's needed in all the places that are needed to make those changes. We have two basic tools: information and relationships, as levers to navigate the way forward to success. So let's go. You may have seen maps like these before. This is Washington, D.C., and the metro area, and the numbers show life expectancy by D.C. metro subway stops. Place matters a lot. We supported the preparation of these maps beginning about 6 to 7 years ago when we supported our first commission to build a healthier America. Their report was titled Beyond Medical Care and focused on the importance of those factors outside or beyond classic health care for our healthiness as a nation. Every analysis of the differences in health between populations concludes that it's the differences in the social factors that are the largest contributors to differences in health. And we wanted a way to make this point startlingly clear, if possible. And we even wrote a piece that had the title that I placed on this slide: Is your zip code more important to your health than your genetic code? A few other points. Life expectancy in the U.S. improves slowly by about 1/10, maybe 2/10 of a year per calendar year. Thus, even a relatively modest numerical difference in years of life expectancy is in fact quite large as a disparity. Or put another way, if we could find a way to double the rate of progress and improvement in life expectancy for the disadvantaged, and keep the progress for the advantaged group just about the same as it has been, it would take over 25 years to make up a 5-year difference in life expectancy between the groups. So the differences you see in this map are huge. and we've seen larger differences in other metro areas. Where maps like these have been produced, they've often catalyzed actions. I visited Tulsa, Oklahoma, and they found that one area of town had a 14-year lower life expectancy than the better parts of town. And that galvanized the medical school and philanthropy and the local governments to begin to concentrate on improving the health of people in that area. Let's look at another map. This is Los Angeles, and these two maps show very different conditions. The one on your right shows the prevalence of childhood obesity. The one on the left shows economic hardship, an index calculated there by the city. They look almost exactly alike. This is a pattern that can be found in many places and with other health conditions. Economic development and health go hand in hand. It's probably not really a surprise when we step back and think about it. But despite these close relationships, public health and community economic development have rarely worked closely together. So, a few years ago, we began to work with the Federal Reserve on a series of conferences and books to look at how investments in low-income communities can contribute to better health, and perhaps how the health value of individual projects could be measured. The Federal Reserve helps lead the financial community in things like developing low-income housing. They can put supermarkets in inner cities, charter schools, health centers. They can put in small parks. There are large tax credits and other funding sources that can be used to lower the costs of the project, thus subsidizing the cost for development. The estimates are that nationally, about as much as $200 billion is deployed annually. Health is influenced by how they construct their projects, maybe by adding those parks, or lighting, or sidewalks, perhaps through reductions in violent crime, or more activity by kids and families, or even just reduced asthma by now having better housing than they used to from cleaner, more modern apartments. How to assess and add in the health-related return on investment to a city, a state, or our nation, due in part to that better health? The slide shows the titles there of 3 chapters in a book that we had: Why Health, Poverty, and Community Development Are Inseparable, Assessing the Health Effects of Community Development, and Early Childhood Development, Creating Healthy Communities with Greater Efficiency and Effectiveness. This is aimed at the financial community. Janet Yellen chose to make her first public speech at the conference where this book was released, as her public speech as chairman of the Federal Reserve Board. And in a session on the book, when people had seen it, these 3 health chapters, the only ones that were related to health, were the ones that the audience thought were most transformative to their thinking. One community development financing institution, called the Low Income Investment Fund, has responded by creating a social impact calculator. Let me give you some context. Suppose that by getting low-interest loans to build apartments, they can lower rent by $500 a month for low-income families. Great. Better housing, more cheaply available. It might help reduce asthma. How much? What's the value of that? They don't know. But we do know that a low-income family that had an extra $500 a month, what they might do with it? Well, they might buy more food, or medicines, or books, make sure their kids got to school. Economists can calculate the value of more income for health, and the community development institutions are starting to look at that and other social returns on their investment. LIF, the Low Income Investment Fund, has now created a social impact calculator so that they know not just how many apartments and how much they can reduce the rent of those apartments, but what are the implications for health overall. You may know that one of the most celebrated successes in the field is Eastlake here in Atlanta. This slide is from Eastlake before the redevelopment. This building had 40% of its apartments declared unfit for habitation. It had high crime, there was a poor neighborhood school, etc. Well, over the last 15 to 20 years, Eastlake has been transformed. In addition to all the improvements in housing, the elementary school is now exceeding the state standards as far as reading for kids in 5th grade, really over 95% there. Violent crime has dropped over 90% as well. They've seen the employment of low-income residents increase. Eastlake's success was one of the drivers to create an initiative called Promise Neighborhoods by the current administration. Education, housing, employment are all important determinants of good health. Poor health itself is both a symptom of poor social conditions and a driver of poverty. Atlanta's former mayor, Shirley Franklin, a supporter of the Eastlake work and the Promise Neighborhoods work, was on our second commission to build a healthy America. And just last year, that commission recommended that the nation fundamentally change how we revitalize neighborhoods, fully integrating health into community development. Mayors and other civic leaders are recognizing that many of the things that are good for health are also good for attracting young families to move to a community and for attracting businesses to locate there. We've heard stories after story from mayors in Oklahoma City, Kansas, Hernando, Mississippi, from business school professors that businesses are starting to use this as part of how they look at a community. So you know that there's a fabulous VW car plant in Chattanooga. Tennessee, as did a lot of states, recruited VW to come there. They gave them all sorts of tax breaks and all of that. But VW got to choose where it would locate. And they chose Chattanooga because it was considered among the healthier places for people to live in Tennessee. We're seeing the local chambers of commerce start to embrace this as well. In Oklahoma City, we visited there. As I said, we went to Tulsa and then to Oklahoma City. I sat with a woman who is the number 3 in the largest natural gas company in the country. She said a few years ago they had failed in the recruitment of someone they wanted. Their family didn't want to come to Oklahoma City. Oklahoma City lost the getting a business to move there. They went to another community because they felt they wouldn't be able to attract the kind of people they wanted to Oklahoma City. Her boss and she said, "We need a better Oklahoma City." So now the private sector has come together. They put resources into redeveloping the riverfront. The city itself, in one of the most conservative states in the country, has a sales tax, 1% sales tax, that every 5 years ends, and then the citizens get to vote on it again. So the city government puts together what they will do with it in the next 5 years in the hopes of passing it. So I've talked already about the riverfront. They're also building 3 large parks in some of the poorer areas of town. In one of the parks, they've got the soccer field for their professional soccer team to practice on. The soccer team gets it free if they take care of the mowing and things like that, and they run camps for the kids. One has been opened, 2 others are on the way. The 50 of the companies in town are sponsoring rowing teams and kids' education. Now, you might not think of Oklahoma City as a place for rowing. You might not think of rowing as the thing that maybe low-income families need the most, but it has, in fact, revitalized interest in that area. And as all of them, while they sponsor their own teams, they also sponsor the education for their community. So now, let's talk about how we generate interest in communities to make changes for health and galvanize leaders from all sectors, not just health. Just yesterday, we released the latest county health rankings, ranking the health of every county in the nation. And this slide shows schematically the structure with fundamental measures of health, mortality, meaning years of life lost before age 75, and morbidity, that's the proportion of people in surveys who say their health is not good or excellent. Then we have the determinants of future health: health behaviors, clinical care, social and economic factors, physical environment. Tobacco use, diet and exercise, alcohol use, sexual activity, access to care, quality of care with measures that are available at the county level, education level, graduation rates, employment, unemployment rate, low income, family support, single-parent families, percent of children in poverty are the kinds of things that are there. It is this ranking of the health status and those determinants of future health that are turning out to galvanize the discussions. Here's the Georgia map. You can see the darker colors are the ones that are not doing so well. I suspect there aren't too many surprises here. If you're interested in your county, you can go to countyhealthrankings.org and look it up and look up all of the rankings. We rank them within each state because so much of the policy levers and the changes are going to either be local or at the state level. I do need to say, Fulton County was one of the 10 large counties that showed the largest decreases in premature deaths over the last few years. Let's go back to that schematic. County Health Rankings has become more than a scorecard. It generates hundreds of local stories. But what's most exciting is it brings in the business community and education and other leaders, because the various determinants of health, one or more, are really centrally important to them. The measures also bring key organizations together, like the local United Ways. The United Ways nationally are using this as their vehicle for starting the discussions in communities and what they should focus on. Other foundations are using their rankings as a basis for priority actions, like the Kate B. Reynolds Trust in North Carolina, which will invest $100 million in 10 communities over several years. We know that corporate philanthropy is using it to decide where they'll make their corporate grants and on what purpose. We now know that several hundred communities around the nation are using them to create action, to start action. We've also begun in the last 2 years to give prizes to communities that are working to improve themselves and their local culture of health, with criteria that include broad-based coalitions, major initiatives that have leadership from multiple sectors. The slide has a photo of the event we had at our foundation to honor 6 of the awardees. And the other photo is of the flag that comes as part of the award being flown from the City Hall in New Orleans, one of our past winners. And while the prizes are for health-related work, we take a very broad view. So for example, one of the winners was Spokane, Washington, where the business community and the school system got together recognizing that their city's future required a well-educated workforce. If they wanted to attract new business, they needed to have a well-educated workforce. If they wanted to keep their children there, they had to have good jobs for them. So this was, again, bidirectional. They needed both. Well, working together in 7 years, they have raised their graduation rate from 58% to over 80%. And they found that the most valuable indicator of the child at risk was 4 absences in 7th grade. So they started whenever the child has 4 absences in 7th grade, they bring them in with their family, they talk about what they can do to help turn that around, get the kid the kind of catch-up that they might need. Now they're moving on to saying they're focusing on a stronger pipeline to good jobs with local businesses. Over 300 communities applied this year from all over the nation, and we'll award the next set of prizes later. Our purpose is to raise the visibility of how communities around the nation are working together to improve their circumstances, and showing that the vision of a culture of health can have practical, successful, sustainable applications anywhere. And while I hope these illustrate for you that we're trying to catalyze action in many places, many more than we can actually fund, and fuel a societal movement on fundamental conditions that affect health everywhere. The next phase, later this fall, we're going to look at the ratio of all of those factors. So whether it's unemployment rate or graduation rates or smoking rates, high county versus low, it will raise the discussion, we hope, from just being local discussions to being statewide on inequity in those states in all of those measures, current health status and those determinants of future health. So I showed you this earlier. I want to make sure you understand that we will not succeed if we can't measure progress, and that communities and their leaders need to feel that the improvements are real and important and that their actions can work. Measurement is crucial to that, but we also have to come to view that we have to think of this as having some of the characteristics of a movement building, to think of the measures of progress as more of a compass than a roadmap, meaning our ultimate destination is clear, but we, individual communities, other partners, can make progress in many different ways. So let me show you how we're beginning to think about measuring progress. We need to make health a shared value, as I mentioned to you. We have seen culture change in a number of places, but we have to make it not just about that issue of tobacco or obesity or seatbelts or things where we have had changes over recent history. We have to make it a shared value, that is where everybody realizes that health is important, health broadly, and that we're all in this together. That we look for cross-sector collaboration, and how are we going to measure that to improve well-being? How many partnerships, how strong they are, how substantial they are. About creating healthier, more equitable community environments. We know that while there's no government program, no philanthropic program can take the place of people making healthy personal choices, many people in our society live in circumstances where healthy choices are almost impossible to make. And we also have to recognize that we need good quality health care affordable for all. We have real challenges in how to measure these meaningfully and how to catalyze demand in places around the nation. But we fully believe that our nation needs to aspire to a more holistic vision of what it means to be healthy. That is where health begins, is nurtured, protected, and preserved, is often in our community, is essentially in our community. We have to have an approach that satisfies our hearts and the hearts of potential partners and our minds, showing that we are confident that we're making progress, and if not, we're going to change what we do. So, in closing, I want to leave you with a few summary thoughts. First, we in health have generally acted as if good health is what people want. It isn't really. What they want is a good life, fulfilling, with enjoyable, warm relationships, meaningful work. If they're like me, I'm a grandparent, want to get to know their grandkids, play with them, see them grow up. Maybe they want to continue work because they find it satisfying and fulfilling, or volunteer or travel, or maybe they need to take care of grandkids while both parents work. Our best chance of having that kind of life is built on not smoking, exercising, being careful what we eat, getting our flu shot, etc. People want good health for a purpose, for a satisfying, meaningful life. We in health and healthcare have been too narrow regarding what we thought of as health and why people want it and why they will work to get it. And thus we've been too narrow on what we've worked on and who we worked with. This narrowness in framing has greatly influenced our civic leaders and the public, so they have not been nearly as aware that how our society is organized, what our policies foster or inhibit, what our communities encourage and our institutions support, are equally as fundamental causes of good or ill health as are the biologic ones. It is research that turns disease and injury from fate's misfortune or bad luck or accident into biologic understanding and potential control. But that research then turns its understanding over to society. And whether it's in medical care or in community health or in transportation or education, it's the policies, the laws, and the practices, the scaffolding of society's culture that must transform research into impact on disease, injury, and improved health. That means that potential policy or social structures inside and outside of medical care become part of the causal chain related perhaps to disease or injury itself, but certainly to the rates and distribution of that disease or injury in our people and communities. That is, to the size and distribution of disparity. We're at a watershed time in our nation's history. We have to be honest with ourselves as a nation. Technologic advancement, or our nation's leadership, is unquestioned, has failed to rein in the growth of medical care costs, nor has it even enabled us to have better health relative to other countries of similar wealth and development, according to big picture measures of health like life expectancy and infant mortality. In fact, even as we've increased our medical care spending by more than $1 trillion a year over the last decade alone, we've gone down in our health ranking. Other countries are simply getting healthier faster than we are, despite our rapid increase in dollars spent on medical care. The fact is that the likelihood of initially becoming ill or suffering an injury, especially prematurely, is really about where and how people live, learn, work, and play. And many people in our nation live in situations where the healthy choice is almost impossible to make. As a nation, we've had an enormous imbalance regarding where we've looked for sources of health and illness and to solutions for disparity. Our most fundamental aspirations as a society, life, liberty, and pursuit of happiness, our aspirations and our inspiration to the world have at their core health and equity. In fact, if you didn't know, the first draft that Thomas Jefferson wrote did not say life, it said the preservation of life, meaning very clearly that you had to have health before you could had the freedom to have the choices and to pursue happiness, which was the sense of fulfillment. So as you can see, I really wasn't totally honest with you when I opened this talk. Health equity is not just the fundamental goal of public health. It is fundamental to our goals as a people and as a nation. Thank you.
Thank you, Jim. Jim's agreed to take some questions, and I just want to emphasize how important the crossroad we're at right now in terms of life and health, and with the investment, the Affordable Care Act, the investment the foundation is making, and the future of health and public health. So let's have some smart questions from the audience.
That's right.
There are microphones on the sides. Larry.
Joe, you made several points about how counties are using the county health rankings.
Yeah.
I would think that there would be a lot of activity in state legislatures as they compete for the best health rankings among the counties. And has that affected state health legislation?
So just so that people are aware, there is a program called America's Health Rankings that the APHA does with United Health, and they do that annually. And those rankings turn out to be influential at the state level. They use some of the same measures. We share some of the people on the advisory groups, but we wanted to be able to bring it locally. But they don't emphasize equity, and that's what our future report will do. And that's where we want to see real changes and recognition that state-level policies can change inequities in their states.
Other questions?
Thanks, Jim, for a really terrific talk and inspiring. You know, as we look across the country, there's a surprising amount of activity in this space. Lots of government work, foundation work, unfunded work as mayors and county supervisors kind of get engaged. And it's not necessarily well organized. How important is it to bring this activity together and create a movement as opposed to really allowing this kind of free-flowing effort at the local level?
As you might expect, we've wrestled with it, and I don't know that we have the right answer, but we're thinking of it in a couple of ways. One is that there are so many different communities will come at it differently depending on who they can bring to the table. They're really committed. We want to encourage that. But where we are really committed, because we think it was an issue in the first efforts at healthy communities that struggled, was we didn't have rigorous measures of outcome. And for us, we began to, should we deal with cancer? Should we deal with tobacco, obesity? Those are things we think are important. But we realize that sort of any community coming together has got to have some shared sense of their values. It's got to be able to say they brought people to the table that are broader than just the hospital and the public health agency, that they have, in fact, looked at equity of risk for families and communities, and that they make health care available. So we thought of those as sort of the foundation for communities creating changes that are going to matter. We are not secure. We will be releasing our first look at potential measures in late May. We think of those as 1.0 measures. We've looked at what's data that's available around the nation that can be used. As you might expect, some of it might be spot on, but some of it's not so strong. But we also wanted to indicate where we're trying to go and invite partners to work with us on what might be better measures, even as they think about how they can help. So we anticipate strengthening those measures over time. But we're more comfortable that there'll be greater variety in the programming if there's stronger commitment to the measures. But the other thing we have to do, where CDC has been a very important partner, is what's the science tell us is likely to work? So the community guide, the guide to clinical preventive services, all of those are also central, because the worst thing would be getting the commitment and then not having communities know what they can do that will work. There's lots of variation in communities themselves and how they need to adapt that science, but it is fundamentally, we want them to work on the best things. Sort of like an oncologist. If you're an oncologist and you have a patient in front of you, you know that the science is going to improve in the future. You've got to work now, though, with the best science that you have. And that's what we have to have communities to do, both so that they're working with the best science we have, but they're ready when the science improves to change what they're doing.
Jim, thanks for your comments, your presentation. You talked about the science, and I'm curious about how the foundation views its role in catalyzing this culture of health. From a strategy perspective, in the past, there have been investments for healthy eating, active living, that were research focused. And so as the foundation rolls forward with the Culture of Health initiative, can you talk a little bit about some of the priorities that you see in terms of the ways that you all can serve as a catalyst to move the effort forward?
Yeah, thanks, Rodney. We've done this in the past, and probably obesity and tobacco are two of the best stories. So when we as a foundation started to get into tobacco work, most of the evidence was around counseling and nicotine replacement therapy. There was very little evidence on the value of price, tobacco taxation, in stopping initiation. So there's always that importance of science, especially science that can be applied at the local level. We funded a fair bit of research early on, and now our central funding is about actually getting more and more people covered by clean indoor air laws, so that that part of the science is applied everywhere, or it could get, like the Martin Luther King quote, puts the progress made at risk. In obesity, when we got into it, we felt the same thing, that the science, there was a beginning coming together of science, but it wasn't strong enough that communities felt they could take it on. There were researchers saying it wasn't good enough. We started to fund a series of reports with the Institute of Medicine. What was the state of the science? Jeff chaired the first report. We don't fund basic research. We tend to fund policy level research. What are the policies that work? How good is that evidence? Are there ways that they can be strengthened? It doesn't have to be policy like state law, it could be, but it might be policies at the school level. So we funded a program with schools where it took the science that CDC, NIH, and others had done and said, well, what are the practical things that schools could do in food that's outside the lunch line, inside the lunch line, physical education, activity programs outside the PE time, what they could do with their faculty, et cetera. And we set up a recognition program so schools that made more of the changes could get a gold recognition or a silver or bronze. About 30,000 schools are working on that now. We also funded a randomized trial, so a type of research that said if they made that progress, how did their kids do? And we found that those that made bronze level or higher, their obesity rate started to go down. So it gave us confidence that we were on a pretty good path. We funded no individual schools. We funded the research and we funded the recognition program in combination with the Heart Association and the Clinton Foundation. So we are very committed to the science, but it's a very applied kind of science because we think that's where we can have our greatest leverage and we can try to find ways to create change around the nation.
Dr. Marks, I appreciate the idea of a generational strategy. Mm-hmm. And I'm wondering, because you all have noticed, because the foundation and others have noticed that things like place and access to employment are so significant. And what we know is that all of those, the original insult that caused that disparity was a social evaluation of people based on the way that they look and the way that they speak, kind of the things we talk about as race and ethnicity. How, if at all, are you all inviting innovation and creativity in changing the narrative that results in those kinds of initial disparities, those structural disparities that are in place anyway?
So that's a great question and one that we've wrestled with. And just so that people are pretty clear, the Declaration of Independence that I quoted from says all men are created equal. They also didn't count women then, and as you may know, blacks were counted as 0.6 of a person in the first censuses. So this is very deep and historic. We've thought about not just changing the narrative, but how can we get the policies to change and reflect that? We also know that we have to recruit others to say that this is something that they can get behind. And so we're looking at the various forms of disparity broadly, that it's not just about one race or heritage versus another, but it's about all of us in it together so that we make it easier for those who might be reluctant to join. We're doing a lot of message research. We've learned a lot about what kinds of framings help people come to the table. So I talked about economics and poverty and things like that. People that are a little more reluctant are quite comfortable with the term economic opportunity. And I'm comfortable using that term if it gets more people to take that on as a direction. We also have a lot of work to do with our own health community. Some of them are reluctant. Budgets in public health have been cut. They're nervous about, can they step up in that kind of leadership? Can they be an advocate for early childhood education that's quality? Can they be confident that that makes a difference? So we're doing actually some research on that. If you don't know, the Federal Reserve in Minneapolis has early childhood as one of its big areas. They've raised tens of millions of dollars for quality child care for the lowest income families, but they will only get that scholarship for that child care if they go to a 4-star child care. So Montessori and others are building new facilities in some of the poor areas of Minneapolis, St. Paul. So we've got to think of it as there are deep, I don't need to tell you, and we don't need to tell this audience, we've seen examples all around the country, deep issues of racism, of institutional racism that undercut us as a society and as a community. We've got to try to overcome those, but I think we have our best shot by broadening the dialogue to bring more people to the table and have it recognized that it is racism, but it's also sexism, it's also income inequality, and it's place. And we know that there's a substantial element of racial and income segregation in a place look. And so but everybody knows we shouldn't see those kinds of differences. So how can we have that happen? That's what we're trying to do. We're very cognizant of how far we have to go. I think we're optimistic in a generation, but we don't see another way forward
for our nation. That's why I said it was with some trepidation that we decided we had to go down this path. We have a board that's very supportive. We're starting to see a lot of engagements by groups that we never thought we would. I never would have thought that the community development field and the Federal Reserve would take this on. They're ready faster than we are ready to give them measures. Fortunately, there are some examples like Eastlake. There are examples like the Beltline, which help bring a community together. That's what we've got to do, and that we're all in this together as a nation, as a community. So I appreciate you raising that, because I don't know that we have the answers, but we're going to, it's a core part of what we've got to learn to address.
Hi, Jim. That was really remarkable. And I see that once you left the South, you learned to talk really, really fast.
I was worried. I told Michael, I said, I think I'm down to 35 to 40 minutes, but ...
Oh, you did it, and it was remarkable. You had so many wonderful ideas there. And I want to say, as I look at this slide, some people see people, places, and poverty.
Yep.
And I see Marshall, Martha, and Marx, the 3 M's there. And to me, being here with this group, it's the evolution of a cohort that is live and well here. And I want to ask you a personal question. That is, how has your own thinking about these things evolved over the past 30 years?
Wow. So we don't have time to go into all of that. So I'm going to say a couple of things, though. I had a great time at CDC and helping to grow our programs in non-communicable diseases. I liked infectious disease. I did infectious disease epidemics early in my career. But when I looked at what was killing people and what was the greatest sources of disparity overall, it was the non-communicable diseases. So I felt I had to go there. That if I was true to the field of epidemiology, I had to go to where the problems were. And that's where I saw them. I was fortunate to have worked closely with Jeff from the beginning in that area. At the foundation, there's greater flexibility than there is at the federal government. And that is very helpful, even though the resources are less. Where my biggest evolution there is, even though people say it's not about the money, it really isn't. It's about leadership. So a person who had been on our board, former chair of Johnson & Johnson, said when he was at Johnson & Johnson, the resource that's in shortest supply at J&J is leadership. And it is that leadership, it's most effective is when it actually doesn't have the authority or the responsibility for managing programs, but it's about who it makes connections with. So that's the idea that information and relationships are the driver is in fact something that I've come to feel very deeply. We have a lot of work to do in making our information more cogent, more accessible, but it's also we've got to make the relationships deeper with organizations that can have reach into hundreds and thousands of communities around the country. So the United Way is a great partner. We funded them a little bit on education about how to use the county health rankings. They're off and running with it. We don't fund them to do anything at the local level, but their locals are using it for their dialogue. We've worked with the YMCA. They teach you these great statistics as you learn. So Ginny is there on their board. The Y has 2,700 affiliates. It sees more kids a day than McDonald's. Now, if you were working on obesity and there was an organization that saw more kids a day than McDonald's, wouldn't you want them to be one of your partners if they were interested? The Y was interested. And we, I think, helped them as they were thinking about their transformation. They have more swimming pools than any other organization. But they were starting to say, what can we do to make our communities healthier places? That's what we funded, so that they started to look at local policies. And then when they got to 4 Ys in a state doing that local policy level work,
We said, now we'd like you to in those states, start with a state Hill Day. And now they fund all of the states to do that. So they've got local boards that are prominent. They've got a commitment to maybe not all the exact things that we have, but an awful lot. And we've got to find partners like that and help knit that together so that you, when you're in a community and you start to say we need to work on an issue, you turn around and there's a whole set of partners there ready for you. So it's not like you're struggling each step of the way, but all of a sudden there are lots of people there. And if you're a health department, maybe some of those coalitions will invite you to the table. You don't have to do that all. My concern had been that public health, we would not recover the budget cuts of the last decade or 6 or 7 years, much less get to the level of funding that public health agencies had thought they needed then. Our only hope is that when they look out and help define what's needed in a community, that they have more partners with more resources than they can say grace over, and they can get the work done with those partners. That's the way that's where we're thinking of as a culture of health.
Great, Jim. We'll have last question here.
Dr. Marks, thank you for the excellent presentation. I have a question about the culture of health, because yesterday I was at a conference call with the Appalachian Region Health Disparity Project, which was funded by the RWJ. And one discussion is that the people in the low-ranking, health ranking area, they may not think they have lower health, which make me think, because I'm from Division of Diabetes Translation, and we have the great National Diabetes Prevention Program, but the participation rate is low. So what's your thoughts on how to engage the people who are in a disadvantaged situation, how to build a culture of health among people? Because of the education and economic level, they may not have the sense to build a culture of health.
I think that's a very important point. And there are several levels to answer it at. First of all, they might not realize it because they haven't thought of they haven't thought about health as the vehicle that gets them the best chance for the kind of life they want. They might not recognize it because of the other changes around. So West Virginia, right in the middle of Appalachia, there was a survey at the beginning of our childhood obesity work that 19% of the children were obese in West Virginia. 1% of parents thought their children was obese. A 19-fold difference. They didn't recognize it. So there is the education, and then there's the second part, that you can make a difference. And that's where we're having to go with our communities, that you can make a difference if you make these changes. So in our obesity work, the last report that we helped fund was called Accelerating Progress in Preventing Obesity and Obesity Prevention. And the central message, it was a long report, but the central message was that the science was good enough now that if communities made the changes that other communities had done, that there was enough demonstration, and stuck with it, in a few years they would see their children get healthier. That sense that it will work and anybody can do it is, I think, central to getting not just the interest, but the commitment from people. And that's part of the education efforts we all have to do, but it's also part of it's why we have to find those stories and make them visible. And that's part of what we're trying to do with our prizes.
Please join me in thanking Jim.
Thanks. Hold on.
Before we let Jim escape from the podium, we have a small token of appreciation for you.
All right, what is this, a Purple Panther?
Well, I hope it's not liquor, so you can take it on the plane. But let's
see here.
There's a little clasp
there. Yeah. Oh, very nice.
Congratulations. Thanks again, Jim. Before we convene, we'd like to make two other announcements. First, we like to thank Gary Nelson and the Healthcare Georgia Foundation for their inspiration and support of the Kreuter Katz lecture series. Gary, would you like to stand, please? Thank you. And obviously, the reason that we're here, besides hearing from Jim, is to really honor the accomplishments of Marshall and Martha. So you guys please stand. The Kreuter Katz lecture is selected by a panel of public health professionals. I'd like to recognize the panel and thank them for their identification of speakers. And the panel includes Larry Green. Please stand when I call your name. Ginny Harris, Linda K. McGowan. And finally, I'd like to take this special opportunity of having our colleagues here and having Jim here to make a special announcement. Not long after this year's judges panel selected Jim to be our speaker, Larry Green reached out to us with plans to honor another outstanding public health professional, his wife, Judith Otteson. And Larry has endowed a scholarship for public health students at Georgia State in honor of Judith Otteson. So Larry and Judith, would you please two stand? Well, it's a very special day, very special group, a lot of good friends. We're honored by your attendance here. I think the questions were smart. The tie selection was poor. But we have our work cut out for us, and the opportunity of a lifetime is in front of us. So we hope we can continue this dialogue. We have a light reception next door. So please join us next door for refreshments and further conversation. Thank you.